So the issues of real clinical practice in the pulmonary arterial hypertension, PAH. This is a huge area, and actually we are quite positive about that. So although this is pretty rare, and partially some of the patients they are getting reimbursement as an orphan patients, but the plus here is that we are actually quite comprehensive for such dramatic groups and groups of drugs for such complicated nosologies as pulmonary arterial hypertension. But now we see that doctors they improved dramatically the understanding of the processes related to that, and now they understand the patient journey, they understand the algorithm of activities, and the most important, they're focused on early diagnosis. So to all of us, almost for all diseases, the most important so the most important message is to use real clinical practice for early and fast diagnosis of all conditions and diseases. That is why when we speak about pulmonary arterial hypertension, now we all speak the same language. So now we know quite a lot about the pathogenesis, and now we understand our most important tasks here for the management of these patients. But if you see here that the average age is 42, so these are quite employed and pretty young cohort of patients that require to be actively socialized to perform in their life and to improve quality of life. In the absence of treatment, please appreciate median of survival less than 3 years. So these are definitely very challenging patients according to their structure. And now we see here that at the same time, there are very many there. They are suffering, children are suffering from that. And this is idiopathic lag, which is important. And from them, 190 children. So we say that these are orphan, and at the same time, we see very high prevalence, 6.6 per 26 million people. So once again, it emphasizes how important is to make correct diagnosis. So associated PAH and idiopathic PAH. So these are similarly the same percentages. So in fact, it's 67%. And what can we do? So this is first of all assessment of the patients, and the objective is first of all to reduce risks and then to increase life expectancy and also to improve the prognosis for the specific patients. The most important what we can provide to the patients so containing the low risk profile. So this is pretty high level of good quality life, good assessment, and opportunity to prolong this healthy life, to avoid fast progression, and then we can do it for the next dozens of years. Also, it's very important to assess the risks initially. That is why here we need to use all possible available tools, including the artificial intelligence, also diagnostic search, to provide multi-parametric assessment of severity of PAH in one specific patient. And what we see by now from the point of clinical pharmacology and patient management, definitely we have some new innovative options that could provide very good results and very good outcomes. So we should assess risks and we should follow the patients to control them properly, to control the dynamics, and to do everything possible that the dynamics of the disease would be positive. Talk about the relevance of real clinical practice in pulmonary arterial hypertension. Well, probably once again, and also we need to understand that correct management of the patients, this is a reduction of burden of very severe disease that currently is seen, and this long-term
лекарственных препаратов, а в частности, один из самых таких на сегодняшний день по эффективности и безопасности доказанных препаратов.
One of the best is Selepsipag, and that this is what was demonstrated and studied in a clinical practice. So this is Griffon clinical study. This is a multi-center randomized clinical trial.
Оно проводилось с участием более 1000 пациентов, и оно настолько было всеобъемлющим, что это было 39 стран, 181 медицинский центр, и наша Российская Федерация также.
So Russian Federation was presented there, and so this is open phase in Griffon study.
Хотелось бы отметить, что именно реальная клиническая практика по препарату Селексипак, она нашла свое отражение в сформированном регистре, который называется СФИАР, и исследование Exposure, где было совокупно 3800 пациентов. Если мы обратим внимание на частоту встречаемости данной патологии, то мы увидим, что это колоссальная.
If you look at the rate of the pathology, we will see really huge rates, and here we see that this is a really good opportunity for all the patients. Now register is multi-center prospective study. So, and it is not just
мы можем наблюдать всю картину его лечения с оценкой эффективности и безопасности, прописываем побочные эффекты изменения режима дозирования, функциональный класс заболевания, его прогрессирование или, наоборот, стабилизацию и даже регресс симптомов. Поэтому такой регистр СФИАР оказался крайне востребованным, крайне важным в данной ситуации. Он отражает динамику всех пациентов, которые получают терапию селексипагом в условиях реальной клинической практики. Характеристика пациентов была сформирована и сформулирована и проведена аналитика первых 500 пациентов.
So first 500 patients here in FCR registry, and here you see how we start. So this is what presented in the European Society of Cardiologists. So who was included here into the registry? So these are all patients aged 18 plus, and this is first treatment of Selexipag, which was administered for the first time less than within 60 days or even earlier before the inclusion into the register. So medical data was collected and analyzed, and in 3 months and until 18 months after that. So the data were finished to collect on December 2019, and in the analysis, first 500 patients were included. So we used a calculator of risk assessment revealed to 0, and also we used Kaplan-Meier method for the calculation of probability of survival, which is important from the moment of start of Selexipag. We looked at the efficacy and safety of treatment. So here on the slide, we can see that all the patients, and we are speaking about the first part of the registry, these are first 500 patients. So mainly they were female patients, approximately plus minus 60 years old. Median of time between the diagnosis and start of treatment from 3-4 up to 7.4 years. So, and here we see that this is pretty long period of time that patients were having the disease, and possibly we need to minimize these periods. Here you see functional class, so mainly this is functional class 2-3 by WHO. So interesting to mention here, what are the patients that were included into this registration study, and actually who actually received Selexipag here? Well, definitely this is idiopathic form of the disease, idiopathic, which is the most important. And we have also induced by drugs, hereditary and toxin associated. So it's important for the understanding of pathogenesis and future pharmacotherapeutical or therapeutical support patients. And when we
мы должны понять, о каких заболеваниях
about these diseases, what are diseases? So practitioners, so the advantages here So we need to understand what is the main portrait of the patients, which requires these are systemic diseases, congenital heart diseases, portal hypertension, and HIV infection. This is very important data that was obtained there.
Also analyzed the basing of the drug, the maintenance therapy. So that was the dose was 1,200 2 times per day. 96% of patients that become part of this register received one more drug of the specific therapy. So in general, 43% had dual therapy and 10 received triple therapy. So, but they were not specific drugs. Mainly they affected the effects of decompensation of the heart system. Mainly those were diuretics and anticoagulants. After 18 months, most of the patients showed improvement and stabilization of risk by the calculator revealed to 0, and 2.7% showed the worsening of the risk reduction, the increase of the risk, which requires additional analysis. But we understand that this disease is very complex, life-threatening, always progressing. That's why this data give us a key to managing these patients. So I would like to remind you that 500 patients were included into the population, and we noticed the change of the functional class during the first 18 months of follow-up, and we may note stabilization of the process, some improvement, almost 1/4 patient improved, and 1/8 or 1/10 showed the absence of the positive dynamics and even worsening of the state. But this is a national process. We just see that on the whole, the course of the disease is very aggressive. The survival also, we looked at the safety and survival, and we see that the most frequent reason of discontinuing selexipag was the development of adverse events. And we would like to draw the doctor's attention to the development of adverse events in such difficult diseases. 11.4% of patients had to discontinue therapy because of adverse events. And none of the lethal outcomes was connected with the selexipag. And looking at these 500 patients, we see the assessment of the drug efficacy, the assessment of its safety, and the opportunity to use different calculators to measure risk in respect of prognosis. So we may model the situation and have very good statistical data. So real clinical practice, the availability of patients in the register allows us to prognose and see our future way. So it is necessary to note that more than 2/3 of the patients received selexipag, and the majority of these patients had been diagnosed earlier. They had degree 2 or 3 by the functional class. No new adverse events were registered. That is important to note. Also, we made exposure trial, a prospective description of clinical characteristics and outcomes of patients who went through the PAH therapy for the first time. Now, the goals of the exposure were to describe clinical characteristics, schemes of therapies, and safety of therapy in patients who started taking selexipag. So there were 3,300 patients, quite a good sampling. It was a prospective study, and almost 1,500 of patients received the selexipag, and others received other antispecific therapy. The duration of the trial was 4.5 years. The patients were followed up for 18 months. I would like to note that this trial had two cohorts of patients. The first one received selexipag, and the patient who received other drugs. Of course, we would not want to know new innovational strategies, and the cohort of selexipag included patients who received this therapy for the first time 1 month prior, before they were included into the trial. So, exposure included only selexipag patients for assessment, where we included demographic data, clinical characteristics, categories of risks, and schemes of treatment. So, you know, we are very, very... may I ask you a question? So our patients get this drug financed by the Circle of Goodness. So is it possible to make a map of data presentation about outcomes of patients who use this drug? Because the informational resource that is necessary to be maintained by the healthcare ministry, we see that all patients must show efficacy within, we must receive data about the efficacy of the drug within 6 months. And for our specialists, it is very important, not only the data that you receive as a result of centralized trials, but also the data within the normative registers. Do we have an opportunity to unify a certain form and recommend it to our patients so that they could objectively assess the therapy of this drug? Yes, of course, we have such opportunities. Thank you for a very generalized and specific question. On the basis of what we have, and we have foreign and our local experience that can be modeled, I think it is necessary to create a system of the doctor's decision support to simplify this process for the doctor and compile specific recommendations that could help us assess the course of the disease in accordance with these recommendations. We shouldn't reconsider our strategy and tactics each 6 months. We have a long experience of 3, 4, and more years, and I think it should be done when we will think how it can be presented as soon as possible. So if you give me 2 more minutes, I will show that today we have great possibilities for pharmacotherapy that affects mortality, progression of the disease, and we see that the main criteria that complicate the disease are very well controlled by these trials. So in conclusion, I would like to say that we will think over and discuss it with you how we see the modeling of the course of the disease of PAH, and with the help of clinical practice, how with the help of RWD, we will be able to improve the situation, and we will, I think that such trials that were made with selexipag provide us with good opportunities of assessing not just one drug. We see just a drug strategy with the help of these trials to treat such difficult diseases as PAH. There is always an opportunity for an educational process for the mapping of the doctors' and patients' journey. These are very important instruments for managing such patients.